The BMI podcast is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. Be sure to check out our description below for our website and social media platforms. I'm your host, Dr. Drew Crawford. I'm a board-certified gastroenterologist and obesity medicine specialist. Thank you for joining me today on the Beyond Measurements and Image podcast. Over the past few episodes, we've talked about the desire to lose weight and setting SMART goals, the role of medicines, the role of exercise. Today, we're going to discuss the role of the brain. It's easy to look at people that are overweight or obese and think that it's just a self-control problem. And to some extent, there is a component of that. The reason that I say that is we know that people who set their mind to losing weight do in fact have the ability to do that. But it's more than that. There's a very complicated neurologic pathway that ends up getting involved. There's so many different factors. For example, did you know that fat cells, what we call adipocytes, they actually secrete hormones that regulate metabolism. And so the bigger you get, the more fat cells you have, the more of these hormones are released. And in the top of the stomach, what we call the fundus of the stomach, there's an enzyme called ghrelin that is released. And it also regulates appetite. And so that's why gastric sleeves and gastric bypass is so effective, because in effect, you've cut that area of the stomach out. And so you've altered a little bit of the pathway that stimulates hunger. So it's all a very complicated process. It's more than just self-control. It's more than just hunger. It's more than just the inability to walk away. Although that is part of it, you have to be able to override these things in the brain. And these things are hardwired. I'm going to discuss a little bit of how some of these pathways work. I'm going to discuss one pathway in particular. And I don't think it's so important that you pay attention to the details of the pathway. There's not going to be a quiz over this, and I don't think that it really affects any particular knowledge when it comes to weight loss. But I just want you to listen to it and understand the complexity that's going on in your brain when you're hungry and when you're full. And that will kind of help you to understand what you're up against and what you need to overcome. Then we'll also, just as an example in this particular pathway, I'm going to discuss a drug just briefly that kind of takes advantage of this knowledge and works to manipulate some of these neurotransmitters and how this goes about working. So we've talked about the hypothalamus of the brain. It's a very specific part of the brain, and it really regulates hunger and metabolism to some point. There are two different components. There's what we call the anorexic and the orexigenic pathway. And so, of course, orexigenic promotes food intake and inhibits energy expenditure. And anorexic decreases food intake and increases food expenditure. So, of course, we think of the word anorexic when you think of a patient with like anorexia nervosa, which is a mental illness, maybe a form of obsessive compulsive disorder that leads to body dysmorphism, where people look at themselves and they're markedly skinny and they think that they're overweight. And so they alter their eating and they decrease their food intake and they do things to increase their energy expenditure. So just keep that in mind. So that disease is called anorexia nervosa. So the anorexic pathway within the hypothalamus does the same thing, right? Decreases hunger and increases energy expenditure. So anorexic pathway ultimately leads to weight loss. Orexigenic promotes food intake and inhibits energy expenditure. So it does the opposite. It is really working to have you hold on to weight, and anorexia is working to have you lose weight. And this is the part that I don't want you to get too wound up on in terms of details and memorizing this pathway, or even necessarily even needing to understand it. The point of it is I'm just going to describe it, because as a physician, I'll describe it and you'll understand that it's a complicated pathway, but I want you to take away from the fact that even as a physician, when I look at this is complicated. And knowing that the brain is, actively working against you in some ways, or doing what it does. I don't know that it's working against you so much, but we're just wired to make sure that we take on food and that we hold our food and that we can survive. That's the point of the brain, is to just maintain the species and allow us to continue to survive. And so these things are hardwired in. So we have to be able to overcome these, and we have to understand the complex interactions. So again, just sit back and listen to the complexity of this. If you want to follow it, that's fine, but you don't need to. So in the hypothalamus of the brain, there's an area called the melanocortin system. It's part of the arcuate nucleus. So in the arcuate nucleus, there are cells called the pro-opiomelanocortin system. And related to that are the agouti-related peptides. So the POMC, the pro-opiomelanocortin system. We'll just call that POMC from now on. The POMC, when they're stimulated, they release a peptide that then binds to the MC4R receptor, which is an agonist for the alpha MSH, which is anorexic. So as you can see, you have this POMC that's secreted, and it ultimately leads to a cascade of events that then inhibits you from wanting to eat. It decreases your appetite. Now, it's interesting. Along with this, when POMC is released, there is a opioid that is released out with it as well. And that opioid is very short acting. It can get bound. And the point of that, the purpose of that is it degrades it quickly so that you in turn don't go prolonged periods of time without eating. Now, on the other side of the arcuate nucleus is this agouti-related peptide, but it works in a very similar fashion, but goes in a different direction. And it ultimately blocks the MSH. Remember, POMC led to the promotion of MSH, and the agouti-related peptide blocks the MSH. So POMC is an agonist, meaning that it promotes it, and agouti-related peptide is an antagonist, meaning that it blocks it. This is just one example in the brain where our blood sugar and our sense of being full, what we call satiation or satiety, all these things feed back into our brain that ultimately release these enzymes and then in turn lead to hunger or a feeling of fullness. So do you remember I spoke early on about a hormone called ghrelin in the fundus of the stomach? And ghrelin is known as the hunger hormone, and it actually stimulates us to want to eat. When the stomach is distended, the ghrelin levels decrease. And so you don't have that feedback going to the brain saying that you need to eat more. But when the stomach's contracted, you release ghrelin, which then in turn goes back to the brain, goes into the hypothalamus, and begins this as well as a host of other cascades that ultimately lead to hunger and the promotion of food intake and the inhibition of energy expenditure. Because remember, we talked about if you're burning energy and you're not taking in energy, it's essentially the same in terms of calories in, calories out. Leptin is another hormone that is actually produced by the fat cells, or what we call the adipocytes. And it too has a role in regulating body weight, hunger, and energy balance. So when fat stores are high, your leptin levels are high, and leptin then serves as an appetite suppressant. So the fat cells in turn work to suppress your appetite, and the ghrelin cells in the fundus of the stomach, they work to promote hunger. All these things don't necessarily work just locally, but actually work through the brain and through the hypothalamus and through this process. So again, I hope that you don't feel overwhelmed by this information or this complex pathway. But I think that it's important to understand that there is a major component of primal development, of just the way we're wired, that we have to overcome in order to lose weight and to maintain a healthy lifestyle. The hypothalamus, of course, it's involved in energy regulation, specifically insulin, leptin, ghrelin. But then you also have another part of the brain, what we call the limbic system. And the limbic system has more to do with feelings and emotions and maybe the desire or the good feeling that you get associated with eating. The limbic system controls cravings, in a lot of ways controls eating behavior. And it's more based on dopamine and serotonin and neurotransmitters that are associated with pleasure. So let's talk about a drug that's out on the market. It's probably not as effective as the GLP-1s in terms of weight loss, in terms of just percentage of body of weight loss. But it does have an interesting mechanism of action, and I think there is a role in weight loss for some patients with this. The drug is called Contrave, and it's a combination drug, actually, of Bupropion and Naltrexone. So Bupropion, you may have heard of, it's also known as Wellbutrin. And Naltrexone actually is a opioid receptor binder. So you've heard of like Naloxone. You hear of people who have drug overdoses and they take Narcan. So you've heard of Narcan or Naloxone. Naloxone and Naltrexone are similar in that they're both opioid antagonists, right? They reverse the effects of opioids on the receptors, but they work in very different ways. And I think when you listen to this, I think it's very important that you understand that Naloxone or Narcan is used for the emergency treatment of the reversal of narcotic overdose. Naltrexone doesn't work in the same way, right? It is an opioid agonist, but it's not used in the emergency cases that you would necessarily need to use Naloxone in. So I think that's important to understand. But it does antagonize that receptor, so it in essence reverses the effects of narcotics. Why does that matter in weight loss? Well, this drug that I'm speaking of, this Contrave, it's Bupropion and Naloxone. Interestingly, Bupropion is an antidepressant, so it actually serves a little bit of a role in that it is affecting the limbic system and helps to regulate some of the cravings. But interestingly, The bupropion also stimulates the POMC cells. Now, let me just stop there for a minute. In the brain, you have these neurons. Imagine like an electrical cord that's cut. Right? You have the two wires. It's close enough where you can kind of arc the distance in between the two. So as the electricity is traveling through from the wall to this cord, it's cut, right? And let's just say the other half of the cord is just a short distance from it. The electricity has to sort of jump that little gap. In the brain, the neurons are like that. And that little gap is called the synaptic cleft. In the synaptic cleft, the bupropion actually decreases the reuptake of dopamine and norepinephrine from that synaptic cleft. So the brains release these enzymes, in this case, dopamine and norepinephrine, and then the neurons reuptake them. So the bupropion inhibits the reuptake. So you have an increased level of dopamine and norepinephrine in the brain. And then that actually leads to stimulation of the POMC neurons. Remember, and the POMC then goes on and binds this MC4R receptor and then the alpha MSH, which then is anorexic, right? So then that decreases your hunger. It decreases you wanting to take in more food, and it increases your desire to expend more energy, at least to some extent. So you can see where using this medication in a weight loss scenario could be beneficial, right? Because you're stimulating that part of the hypothalamus that is inhibiting food intake and promoting energy expenditure. So you can see where that'd be very handy. But then let's talk about the Naltrexone. If you remember when I said when the POMC is released, it also is released with a little opioid receptor on it. And that actually serves as a negative feedback loop, because then what happens is you want to degrade that POMC. Your body wants to degrade that because you don't want to not eat. As an organism, we have to have energy intake. So just our primal brain, just the primitive nature of our being, doesn't really care what we look like. I mean, to some extent, that's important from a primal perspective, right? Because we have to be attractive to the opposite sex so that we can mate, so we can propagate the species. But just on a primal survival level, we need to eat. We need to exist. And so what happens is when that POMC is stimulated, remember that goes down the pathway to decreasing your food intake. So that wants to keep you lean. It's not trying to get you fat. It's not trying to put on extra weight for stores in case you don't have the ability to eat on down the road. In 2025, in the US and in the developed countries, we are so fortunate that starvation is very uncommon. But think about just as a primal person, right? Just primitive. Back in the day when we had to eat, and we might go days or weeks without eating, we needed to be able to pack on stores. And so anything that was going to inhibit our ability to take in food and to continue to take in food, well, that had to be kiboshed. And so the mechanism is this little mu receptor. And then what happens is that POMC then would degrade, and then it would lead back into this regular baseline metabolism where we weren't trying to not eat, where our brain wasn't telling us not to eat. So on this Contrave, remember, it decreases the neuronal reuptake of dopamine and norepinephrine, which then increases all those enzymes in that synaptic cleft, which then in turn stimulates the POMC, which then goes down and leads to the anorexic state, where we're not wanting to eat and wanting to expend energy. Now, the bupropion is stimulating that. The naltrexone, it goes in and it binds that little mu receptor. It binds that little opioid receptor so that then the POMC can stay longer, it can stay present longer, which can then propagate the effect of that. So again, this is all a very effective scientific approach at weight loss. So you're increasing the anorexic pathway within the hypothalamus, and you're inhibiting the breakdown of that, or at least you're slowing it down so that you can continue to decrease the desire for energy intake, decrease the need to eat, and promote energy expenditure. And then along with it, the bupropion also has the added effect of working on the limbic system, which helps us with cravings, particularly of sugars, salts, fats. And so it's a two-pronged approach. So it's a great medication, at least on paper. It's really good. It does look like, when you look at the data, it does look like that you can sustain about 5 to 10% weight loss on this medication. The biggest side effect that we see with this is it can cause nausea in a lot of patients. Just like we talked about with the GLP-1s, there are pros and cons, and there are some people that just should not be on Contrave. Let's talk about those. People who have uncontrolled hypertension, if you have a history of a seizure disorder, if you have anorexia nervosa or bulimia, right? If you have an eating disorder, if you're on chronic opioids or even opioid antagonists, or if you've been on a monoamine oxidase inhibitor in the last 14 days, that's a specific kind of antidepressant. Those are reasons that you should absolutely not be on Contrave, and you need to talk with your physician about that. In addition, there have been reported cases of suicidal ideation on this medication. Seizures disorders, hypertension, glaucoma, those are all known side effects, and obviously from the side effects come the contraindications or the reason not to take it. So about a third of people that go on this have nausea. About 20% end up with constipation. About 17% end up with headaches. But it's a fairly well-tolerated medication, and it works fairly well. And then, of course, like any of the medications, the real question is who should be on it? Well, it's indicated for patients that are obese, that is a BMI greater than 30, or if they have a BMI greater than 27 with one weight-related comorbidity. Medication is taken once daily, and oftentimes you have to increase up to the dose. So how's the medicine taken? Basically, you have to titrate up to it within a month to get to the standard dosing, which is 8 milligrams of Naltrexone and 90 milligrams of Bupropion. So in week 1, you take 1 pill in the morning. And then in week 2, you take 1 pill in the morning and 1 pill in the evening. Week 3, you take 2 pills in the morning and 1 pill in the evening. And then by week 4, you take 2 pills in the morning and 2 pills in the evening. And that's how it continues to go. Like I said, nausea seems to be the biggest limiting step in terms of continuing on the medication. It does lead to about a 5 to 10% weight loss. And of course, you want to couple this with exercise, dietary modifications, and a standard plan like we've discussed before. I'm your host, Dr. Drew Crawford. Join me next week as we go beyond measurements and image and build a healthier lifestyle and elevate your well-being on the BMI podcast. See you then.